Today we're going to talk about Chapter 18 in the ICD-10-CM Codebook, the 2017 Guidelines. Chapter 18 is for signs, symptoms, and abnormal clinical and laboratory findings not elsewhere classified. First thing we're going to do is look at some general notes. I have two slides that talk about the general notes that you might also find at the beginning of Chapter 18 in the Codebook. The conditions and the signs or symptoms included in Chapter 18 consist of, I think, 6 bullet points here. Cases for which no more specific diagnosis can be made even after all the facts bearing on the case have been investigated. In other words, you just don't know what's wrong, so the doctor is going to say code the signs and symptoms. Second bullet point, signs or symptoms existing at the time of the initial encounter that proved to be transient and whose causes could not be determined. So the person had the sign or symptom, and before they could really get it worked up, it was gone. That's when you're going to code signs or symptoms. The third bullet point, provisional diagnosis in a patient who failed to return for further investigation or care. Some appointments were made for follow-up investigation by the physician, but the patient never came back. So the only thing you can really code would be the signs or symptoms. Fourth bullet point, cases that are referred elsewhere for investigation or treatment before the diagnosis was made. Let's say a child goes into Denver Health, they can't figure out what's wrong, they transfer the child to Children's, but they're going to have on the Denver Health chart just the signs and symptoms because that's all they knew at the time the child was there. The fifth bullet point, cases in which a more precise diagnosis was not available for any other reason. In other words, it doesn't fit any of the above criteria. You just don't have a reason or you don't have a final diagnosis. And the sixth and final bullet point, certain symptoms for which supplementary information is provided that represent important problems in medical care in their own right. So if, let's say you're doing some research and you're following a certain condition and there's a symptom that you always see on, let's say, 60% of the cases, you might want to be coding that symptom to follow it to see if maybe there's something else going on. But you would have to have direction from the researcher or from your provider or your attending physician before you as a coder would know that. So those are all things that might come into play if you were working in a research hospital or in a general hospital where you've got these cases where there is no final diagnosis for any of these reasons. The first guideline has to do with the use of a symptom code. In the case that's been given here, the patient was seen in the ED with complaints of chest pain of unknown origin. He refused admission to the hospital and refused completion of any diagnostic workup. In that case, all you can code is the chest pain. And when you look in the index under the chest pain, there are several R codes that are differentiated by various descriptors like where on the chest, the central chest, or other parts of the chest that, or other descriptions of that pain. But when you're just given something like this, chest pain of unknown origin, you would choose the R07.9. And this rationale for this particular scenario would be a code that would be used when a related definitive diagnosis was not confirmed by the provider. This guideline has to do with the use of a symptom code with a definitive diagnosis code. This is when you've got signs or symptoms that are not routinely associated with the diagnosis. You would want to code those. You would not code signs or symptoms that are inherent to a disease process. In this particular scenario, the patient has pneumonia with hemoptysis, and not everybody that has pneumonia has hemoptysis, so you would code that. And in case you're wondering, hemoptysis is blood in the sputum. Here's another example of that same guideline. The patient has abdominal pain due to acute appendicitis. This is a reminder that you would not code something that is inherent to the condition. If you have appendicitis, of course you have abdominal pain. So you would not code the pain, you would only code the appendicitis. And I do have a note here to remind you that the codes are different for appendicitis and acute appendicitis, so you really want to be looking at your documentation. The patient was admitted with acute gastritis with hemorrhage. This is an example of some of those combination codes that do include symptoms. This particular one does. The acute gastritis with bleeding, K29.01, is a code in and of itself. It includes the hemorrhage or the bleeding, so you would not code the bleeding separately. This particular guideline is not in your description of guidelines in the front of Chapter 18, where it gives you these examples I go over, but I wanted to include it because depending on where you work, you might really use these codes. In the nursing home where I have worked 4 years of my career, we did use fall codes because of patients. It's pretty typical in a nursing home for patients to fall. The difference is the R code is when you don't know the cause of the fall, so you would just be coding the fall itself, and then the Z code would be when you have a history of falling. This particular scenario, the patient is seen in the ED after having fallen at the nursing home. This is his third fall over the last 10 days. He has a history of falling over the last 2 years. So you would put those two codes, both of those codes would be used in this case because they're both appropriate to use. Just a reminder, when we go through these guidelines and different scenarios, they're so short because we're trying to capture certain things. In the real world, you would have an entire chart, and a person in a nursing home is going to have at least 6 or 7 diagnoses. But just keep in mind, these scenarios are just to help you understand the application of a specific guideline. In the real world, the charts would be much bigger. This is a very busy slide, but I wanted to keep everything on one slide to try and talk you through it and how the guideline applies. There's very few times as a coder that you can take documentation that isn't the physician's. You may recall you could take nursing documentation that stages an ulcer. You could take dietitian information that talks about the BMI. And in this case, you can take the EMT's documentation from the field for the different components of a coma scale. It's an important thing to remember. In our scenario, the patient is a 23-year-old found down after an unknown injury with a skull fracture of the frontal bone, with concussion and loss of consciousness of unknown duration. EMS evaluated the patient in the field and reported the individual Glasgow coma scores. You see 3 scores given here. Score number 3 is equal to eyes open to speech. The verbal response, score number 4, is confused but coherent. And motor response, number 6, corresponds to obeys commands fully. There are codes for those scores. Our rationale tells us you're going to code the coma scale scores are sequenced after the diagnosis scores. So the first thing you're going to do is code the frontal skull fracture. You're going to have a 7th character A for the initial encounter. Then you're going to code the concussion with the loss of consciousness of unspecified duration because we don't know what it was. We're going to add a 7th character A for initial encounter. Then when we get to the coma scale scores, they will also have a 7th character. But this 7th character is not a choice of initial, subsequent, or sequela. This 7th character has to indicate where the score was taken. The example we've been given, the 7th character is 1 that indicates the score was assigned in the field by the EMTs. All 3 of the coma scale scores have to have the same 7th character, not the same 7th character that the diagnosis codes have. Important to remember. Then I have the rationale there from this particular coding guideline. It goes through everything. The only thing that isn't covered in this scenario is at the very bottom in purple, at a minimum, report the initial score. That would also be from the EMTs, or the facility may say, no, we don't want the total score, we want separate scores for the eye opening, the verbal, and the motor response. But if you had a total score, you would code R40.24. Only the total score would be documented, not the individual scores, so one or the other, according to our guidelines. This is important when you are working in any hospital that has a trauma unit. You will see head injuries, you will see loss of consciousness, you will see EMTs bringing them in comas. The Glasgow Coma Scale is very helpful to physicians who are looking at rehab for this patient and where do we go from here, the next step. Sometimes the prognosis is important. Depending on the physician and the facility, they look at different things. But I would ask you, because of the importance of this slide, that you would review it more than once. So you understand that you do code those individual scale scores. They must all have the same 7th character, but that 7th character is not the same 7th character as the diagnosis codes. Quite different. And this guideline is the SIRS due to a non-infectious process. SIRS is systemic inflammatory response syndrome. This particular one is due to the pancreatitis. The guidelines tell us you're going to code whatever the underlying condition is first. In this case, it's the pancreatitis. Then you're going to code the R65.10 if it's without acute organ dysfunction, and if it's with acute organ dysfunction, it would be R65.11. If you have any questions about the Chapter 18 coding guidelines, please post them in the discussion board. I'll do my best to answer them. And have a good day.